Okay, this recording is for the 32nd day of the Final Frontier NPTE course. March the 10th, Tuesday, it's going to be over TBI and GCS scale in the O'Sullivan book and a little bit of Therapy Ed. They use the 6th edition. These are the pages from the 6th edition. I use the 7th. And so the readings is going to start at early medical management. So I'm pulling up the book here. And we will start the reading.
Early medical management. Medical treatment following brain injury starts at the scene of the accident. Early resuscitation with the goal of stabilizing the cardiovascular and respiratory systems is important to maintain sufficient blood flow and oxygen to the brain. 91 Once the patient arrives at the medical center, the primary goals are to minimize secondary brain injury by optimizing cerebral blood flow and oxygenation, stabilize vital signs, perform a complete examination, identify and treat any non-neurological injuries, and continuously monitor the patient. 92 Systolic blood pressure should be kept above 90 mm Hg and oxygen saturation above 90%. 90 Patients with severe injury and some with moderate injury will need to be intubated. The patient's neck should be stabilized with a collar and the head elevated 30 degrees. 90 This is done to protect the spine in case of instability, as well as avoid an increase in IQ. The GCS is used to determine the severity of the brain injury. A complete neurological examination is also done. Additional information about the extent of the injury is obtained through X-ray films and neuroimaging studies such as CT and MRI. This is done to determine if neurosurgery is warranted. Intracranial hematomas or other mass lesions may need to be addressed surgically. Cerebral perfusion pressure, CPP, and IQ is monitored. 93 For patients with a GCS of 8 or less, any acute abnormality on CT, systolic pressure of less than 90 mm Hg, or age greater than 40 years, IQ monitoring is recommended. 90 However, some patients may not require continuous IQ monitoring. 94 External ventricular drains, a subdural bolt, and a fiber optic catheter provide methods of monitoring IQ. Elevated IQ can be treated with the use of sedating medications, moderate head-up positioning, head elevated to 30 degrees, osmotherapy, hypothermia, surgical decompression, and barbiturates. 91 Intracranial pressure should be less than 20 mm Hg and CPP greater than 60 mm Hg. 90 If IQ cannot be treated successfully, inducing a pharmacological coma or surgical decompression may be necessary. The CNS neurotransmitter dopamine is thought to increase arousal and attention through the reticular activating system. Medications that act as dopamine and norepinephrine agonists may increase arousal in patients with disorders of consciousness. 96 Amantadine is used to increase levels of arousal and the rate of recovery. 98 Other medications that can be used to increase levels of arousal are methylphenidate and bromocriptine. 95 Methylphenidate has been shown to decrease IQ and hospital length of stay in patients with severe TB. 99 Conversely, dopamine antagonists such as haloperidol should be avoided, as they may delay or slow recovery. 101 Transcranial magnetic stimulation and deep brain stimulation are other promising interventions that may help improve levels of arousal and outcomes in patients with disordered levels of consciousness. However, the efficacy of these treatments has not yet been demonstrated. 95 The remainder of this chapter is divided into 3 main sections. 1. Physical therapy management of patients with severe to moderate TB during the early stages of recovery. 2. Physical therapy management of patients with severe to moderate TB during active rehabilitation. And 3. Physical therapy management of patients with mild TB. Patients in the early stage of recovery after severe to moderate TB often demonstrate an altered level of consciousness. See above for detailed discussion. The primary goals of physical therapy in this early stage of recovery are early mobilization, preventing secondary complications due to the TB and associated prolonged bed rest immobilization, and initiating family education. The examination and intervention procedures described in the section on physical therapy management during active rehabilitation are likely to be used with patients early after injury and who have higher levels of consciousness. Examination. The first step in beginning an examination at this early stage of recovery is to conduct a complete medical record review. Because the patient may not be medically stable and will likely have various contraindications, precautions, and complications that may impact physical therapy interventions, it is important to obtain all critical information from the medical record, nursing staff, and physician before actually seeing the patient. The patient may be on a ventilator with ongoing monitoring. He or she may have weight-bearing restrictions owing to musculoskeletal injuries or open wounds. A thorough medical record review provides a comprehensive perspective about the patient's condition, as well as a complete understanding of the precautions and contraindications that must be observed during the examination and subsequent treatment. Because the patient's medical status may be dynamic at these stages, it is important to check with the patient's primary nurse before beginning any session. Team members should always observe universal precautions and may need to wear gowns, gloves, and/or masks or other personal protective equipment when treating the patient. It is vital to perform a comprehensive and standardized examination to determine level of consciousness, coma versus vegetative state versus minimally conscious state. 45. 102. There are a variety of challenges associated with accurately determining the patient's level of consciousness. Limited motor function, communication impairments, sedating medications, impaired sensation, and impaired executive function can impact the patient's ability to respond to sensory stimuli and commands. The examination should be performed in a closed environment, in a structured manner at multiple times in order to capture the patient's response over a period of time as he or she may not be consistent. The entire team should do the exam with all members carefully documenting the patient's response. The Coma Recovery Scale Revised, see NRSA, see below for details on this test, is strongly recommended for this purpose. 48,103. An appropriate determination of level of consciousness is critical, as patients with disordered levels of consciousness are easily misdiagnosed. A misdiagnosis at this early stage of recovery can lead to a lack of appropriate rehabilitation services and poorer outcomes. In addition to examining arousal, attention, and cognition, other key areas to examine include the following: coma integument integrity, sensory integrity, motor function, range of motion, reflex integrity, ventilation and respiration gas exchange. Patients with severe TBI who are in a low arousal state may present with abnormal tone and posturing. Primitive postures may include those associated with decorticate or decerebrate rigidity. In decorticate rigidity, the upper extremities are in a flexed posture and the lower extremities are extended. With decerebrate rigidity, both the upper and lower extremities are positioned in extension. Abnormal tone may take the form of spastic hypotonia. This may range from spasticity that severely affects the entire body and greatly inhibits normal, functional movement, to lesser levels of tone that affect individual muscle groups. If not medically contraindicated, the examination should include early mobilization such as assisted bed mobility and sitting, and if possible supported upright posture standing. The therapist should monitor vital signs and observe for changes in arousal and motor function during assisted mobilization. A more upright posture may change the patient's level of arousal compared to when he/she is supine in bed. When appropriate, the patient should be transferred into a wheelchair. The patient may require the assistance of 2 to 3 people to transfer at this stage. In most cases, a reclining or tilting space wheelchair is the best option for positioning, with a specialized pressure-reducing cushion. Often it may require several treatment sessions to complete the entire examination. Because early patient status is often dynamic, any signs of progress or regression should be carefully monitored and documented. Outcome measures arousal, attention, and cognition. The Coma Recovery Scale Revised, CNRSA, is recommended to assess patients with disordered consciousness. 104. The CRSR is a valid and reliable 23-item measure with 6 subscales: auditory, visual, motor, oromotor, communication, and arousal. 105 scores range from 0 to 23. Data are useful in distinguishing between different states of consciousness: vegetative state, minimally conscious state, and emerging, determining the prognosis, and informing treatment planning. 105. The Disorders of Consciousness Scale. DOCS is a valid and reliable scale also designed to measure arousal and neurobehavioral recovery in patients with disorders of consciousness. 106,107. It consists of 23 items, which assess social knowledge, taste, swallowing, olfactory function, proprioception, tactile sensation, auditory function, and visual function. Scoring is based on patient response and includes no response, generalized response, or localized response. The DOCS can be used to differentiate states of consciousness, that is, vegetative state and minimally conscious state, and assist in determining prognosis for recovery. A manual and video training are available for the DOCS at www.query.research.va.gov/tools/docs_training/ the Rancho Los Amigos levels of cognitive functioning, LOCF. Scale is a descriptive scale used to examine cognitive and behavioral recovery in individuals with TBI, box 19.3. As they emerge from coma. 108. This scale does not address specific cognitive deficits but is useful for communicating general cognitive and/or behavioral status and for treatment planning. The 8 categories describe typical cognitive and behavioral progress after a brain injury. Patients may plateau at any level. The LOCF has been shown to be a reliable and valid measure of cognitive and behavioral function for individuals with brain injury. 109. Plan of care outcomes goals. A list of general goals and outcomes anticipated for patients in levels I, 2, and 3, LOCF, are presented in box 19.4. These can be used to guide the development of specific anticipated goals and expected outcomes for an individual patient. Interventions. Early mobilization. There is a developing body of evidence that early assisted mobilization is an important intervention for individuals with disorders of consciousness and that patients with disordered consciousness can benefit from early rehabilitation. 72,102,110. 111 studies of patients in the ICU have found that early assisted mobilization is safe and results in shorter length of stays, greater likelihood of home discharge, lower incidence of secondary complications such as infections and pressure ulcers, and improved outcomes. 112. 115 contraindications to early mobilization included unstable spine and increased type. Precautions include weight-bearing restrictions, skin and joint integrity, autonomic instability, and cardiovascular status. Early mobilization should be undertaken in a systematic manner. The physical therapist should closely monitor vital signs and observe for changes in level of arousal during the intervention session. A hard cervical collar may be useful to assist with head control. A tilt table, or specialized tilt table with a stepping system built in, can be used to safely assist the patient into a standing position and has been shown to improve level of consciousness. 116. A body weight support, EWS. System used either over ground or over a treadmill can be used to safely assist the patient to a standing position and take assisted steps. 111. Other interventions that can promote early mobilization included passive seated bikes that use a powered system to pedal, functional electrical stimulation, RES, bikes, and assisted sitting. Importantly, physical therapists should not automatically assume that patients with low levels of arousal cannot be mobilized. Early mobilization may be an important active ingredient to promote beneficial neuroplastic changes to improve outcomes, preventing secondary impairments because of the patient's inability to move at these levels. He or she is susceptible to secondary impairments such as contractures, decubitus, pneumonia, and DVT. 64. If prevention is not addressed early, these impairments are likely to impede future progress and can be life-threatening. Proper positioning both in bed and in a wheelchair is essential. Appropriate positioning will assist in preventing skin breakdown and contractures, improve pulmonary hygiene and circulation, and may modify muscle tone. When the patient is in bed, the head should be kept in neutral. The hips and knees should be slightly flexed, but range of motion, ROM, should be monitored to ensure that contractures do not develop. Splints may be used to assist in positioning. Special boots can be used to position the foot to prevent foot drop and skin breakdown on the heel. Figure 19.3. Turning will help prevent skin breakdown and pneumonia. Patients should be repositioned every 2 hours when in bed. Specialized air mattresses are another effective way to assist with the prevention of pressure sores. Serial casting may be used to maintain or improve ROM. 117-119. Serial casting is often used for plantar flexor or biceps contractures. With a plantar flexion contracture, the ankle is stretched into as much dorsiflexion as possible and then the short leg cast is applied. Fig 19.4. In approximately 2 to 5 days, the cast is removed. The muscle is stretched again and another cast is applied. This procedure is repeated until satisfactory gains in ROM have been achieved or until no further progress is made. Because the individual with brain injury is likely to have impaired sensation and communication, as well as behavioral deficits, there is a risk of skin breakdown or the patient hurting himself or herself or others with the cast. The decision to use casts should be made carefully. The benefits and possible side effects should be thoroughly discussed with input from appropriate team members. It is also important to monitor the patient after the cast is applied. Hands-on experience under the supervision of a skilled clinician is recommended before attempting cast applications. Proper wheelchair positioning is important. 120 because of reduced postural control at these levels, a reclining wheelchair or a tilt-in-space wheelchair is typically required. Proper pelvic positioning and head positioning are key elements in promoting good posture in a wheelchair. Refer to Chapter 32, Seating and Wheeled Mobility, for further discussion of this topic. Respiratory care practitioners, physical therapists, and nurses often use postural drainage, percussion, vibration, and positioning to prevent pulmonary complications and improve pulmonary function. 121 Sensory stimulation. Sensory stimulation is an intervention used to increase the level of arousal and elicit movement in individuals with low levels of arousal. The theory is that by providing stimulation in a controlled, multisensory manner, with a balance of stimulation and rest, the reticular activating system may be stimulated, causing a general increase in arousal. 122 In general, multisensory stimulation involves the presentation of sensory stimulation in a highly structured and consistent manner while the patient is closely monitored to determine his or her behavior in response to the sensory stimulation. Following sensory systems are systematically stimulated: auditory, olfactory, gustatory, visual, tactile, kinesthetic, and vestibular. The value of sensory stimulation for patients who are slow to recover remains in debate. A systematic review published by the Cochrane Library suggests that there is no reliable evidence to support or rule out the effectiveness of sensory stimulation programs for this patient population. 123 A different result was found in a more recent systematic review that suggested strong evidence for multimodal stimulation to increase arousal and alertness of persons in coma and persistent vegetative state. 124 The different findings by these two systematic reviews may be due to when the reviews were conducted, the limited number of studies in both reviews, small sample sizes in most of the studies, difficulties with accuracy and consistency related to measuring level of consciousness, and limited number of studies with strong research designs. Family education. Family education at this early stage after injury is critical. It is important to provide a realistic and consistent message to family members regarding prognosis. Family members should be included in decision-making when determining the plan of care and goals of physical therapy. Families should be educated on how patients with disorders of consciousness present and the differences between reflexive and purposeful movements. Since family members may be with the patient often, they can be taught how to perform ROM exercises and learn how to position the patient to help prevent secondary complications. Family members can also assist with early mobilization interventions described above. Because some patients with TBI may not achieve full independence, family members should also be instructed in how to provide assistance with basic ADLs. Although family members value physical therapy, they may also view it negatively if they perceive it causes the patient pain or distress. So it is important to promote open communication with them. Physical therapy management of moderate to severe traumatic brain injury during active rehabilitation. As patients with severe to moderate to recover, they require extensive and protracted rehabilitation across a variety of settings throughout the continuum of care. This may include acute and subacute inpatient rehabilitation, post-acute rehabilitation, day treatment program, and outpatient or home care. The many cognitive, physical, and/or behavioral impairments that affect activity levels and social participation often necessitate multiple episodes of physical therapy care over the patient's lifetime. Goals and intervention should be focused on the patient's abilities and personal goals regardless of setting and episode of care. examination regardless of injury chronicity. Some patients with TBI will have cognitive and behavioral impairments that pose barriers to the examination process. These barriers may include disorientation, confusion, physical aggression, memory deficits, and limited attention span. It may be difficult to gather data using standardized tests and measures, such as goniometry or manual muscle testing, because the patient may be unable to cooperate. In these cases, the therapist must utilize observational skills as the patient moves to gain insight to the extent of the body structure function impairments and activity restrictions. The physical therapist should determine the patient's cognitive abilities, because these will affect the capacity to relearn motor skills, including orientation, attention span, memory, insight, safety awareness, and alertness. Key initial questions that warrant consideration include the following. Is the patient able to follow commands, one-step, two-step, or multi-step commands? Is the patient oriented to person, place, and/or time? Does the patient recognize family members? Does the patient demonstrate any insight into what has happened? It is beneficial to consult with other team members, especially the SLP and OT, to obtain additional information about the patient's cognitive status. As the patient's cognitive and behavioral impairments become less obtrusive to the process, the physical therapy examination should include the elements and outcome measures found in box 19.5. Depending on the status of the individual patient, some of these areas may be screened, whereas others require more in-depth examination. Determination of the patient's functional abilities should be done in a variety of environments, because some patients may perform well in the closed environment of a private room, but performance may deteriorate in an open environment with multiple distractions. Section 1 of this book, chapters 1 through 9 on clinical decision-making and examination, provides a detailed description of procedures, tests and measures, and specific outcome measures for examining the above-mentioned areas. A brief description of some of the more clinically useful outcome measures for individuals with TBI follows. Outcome measures. Body structure function balance. The Berg balance scale is a valid and clinically useful measure of balance in individuals with TBI. 125-127. The Berg balance scale, together with functional status measured using the FIM, may assist predicting inpatient rehabilitation length of stay, falls during rehabilitation stay, and functional gains during rehabilitation. 125,126. However, as patients improve, the Berg balance scale may exhibit a ceiling effect. 128. A community balance and mobility scale, CB&M, by Howe et al. 129 is an instrument developed specifically for patients with persistent balance deficits following TBI. The CB&M is a reliable and valid tool that assesses higher-level balance abilities typically associated with community mobility. This tool shares similarities to the high-level mobility assessment tool, HEMAT, developed by Williams et al. 130,131. The HEMAT is a unidimensional measure of higher-level motor performance for individuals with TBI. The test items in both are more difficult than general measures of balance and functional mobility and are intended to quantify abilities required of physically demanding vocational and social roles, as well as sporting activities. A revised version of the HEMAT has a minimal detectable change score of 2 points. 132. Attention and cognition. The MOT attention rating scale, MARS, is an observational rating scale that provides a reliable and valid measure of attention-related behavior after TBI. The scale allows the therapist to rate a patient's behavior on a 5-point scale across 22 items that capture the effects of impaired attention on cognitive and motor performance. 133. Other measures of attention most often employed by neuropsychologists include the test of everyday attention. 134. And the trail making test part B. 135. Though all three of these measures capture attentional deficits and may serve as useful global outcome measures, they will be less helpful in measuring changes in attention behavior attributable to physical therapy interventions. The Galveston Orientation and Amnesia Test is a measure of PTA. 136. The GOAT is administered by asking a series of standardized questions related to orientation and the ability to recall events before and after the injury. Scores between 100 and 76 are considered normal, and patients with scores below are considered to have PTA. The GOAT has high inter-rater reliability and is a valid measure of PTA. 136,137. The OLOG measures orientation to time, place, and circumstance. 138. It can be used for serial assessment of orientation to document improvements during rehabilitation. 139. It is reliable and valid, and can be used to predict outcome. 138,140 measures of dual task performance. See later discussion, are more specific to physical therapy practice. Behavior and safety rehabilitation teams often use an outcome measure that captures the impact of behavior and safety on overall independence. The agitated behavior scale measures the type and degree of agitation after TBI. 141. The supervision rating scale 142 provides a one-step method for rating a patient's current level of supervision, ranging from independent to full-time direct supervision. The neurobehavioral rating scale revised is a 29-item multidimensional, clinician-based assessment instrument designed to measure neurobehavioral disturbances. 143. The items cover numerous cognitive and behavioral constructs such as memory, attention, communication, mood, and agitation. Outcome measures, activity and participation, global function in the FIM. 144,145 is a commonly used measure of functional mobility, ADL function, cognition, and communication. It was designed to measure level of disability and burden of care in individuals undergoing inpatient rehabilitation and is useful for monitoring patient progress and evaluating outcomes. The functional assessment measure, FAM, 146,147 was developed as an adjunct to the FIM. It includes functional areas not addressed in the FIM that are important for individuals with TBI and stroke. The other items include community access, reading, writing, safety, employability, and adjustment to limitations. The FIM, in combination with the FAM, is a valid and reliable measure of disability after TBI. 148. In addition to measuring the amount of physical assistance required to perform a functional task, the therapist should also analyze how the patient performs the task. A movement analysis. 149 of how functional tasks, such as stand, rolling, etc., are performed will aid the therapist in identifying the motor function and other impairments that underlie specific activity limitations. Community reintegration and quality of life rehabilitation teams commonly employ the use of a participation level measure that quantifies the extent of reintegrating to social, familial, and vocational roles. One such measure is the Mayo Portland Adaptability Inventory, 150,151, which is frequently used in post-acute rehabilitation. Another, similar measure is the Community Integration Questionnaire, SIC.152. The SIC consists of 15 items relevant to home integration, social integration, and productive activities. Whiteneck and colleagues 153 developed the participation assessment with recombined tools objective, Part O, which combines aspects of other participation level measures. The Part O is a 24-item participation measure that is currently being used by the Traumatic Brain Injury Model System for use in clinical trials and outcome measure validation studies. 154. Another useful measure is the quality of life after brain injury tool. 155. 156. This is a health-related quality of life measure with 37 items and 8 subscales addressing issues of thinking, feelings and emotion, autonomy in daily life, negative feelings and perceived restrictions. Given that subjective reports of dizziness are common following head trauma, the dizziness handicap inventory may be helpful. 157. This 25-item inventory is designed to evaluate the patient's perception of the effects of dizziness on their daily functioning as measured across functional, emotional, and physical domains. The measure specifically addresses the perceived impact of dizziness on daily life in the home and community, making it most appropriate for use in later stages of recovery, for example, outpatient setting. Locomotion gait deficits are common following TBI. 69 classification systems of gait disorders can assist in clinical decision-making, selecting interventions, and determining a prognosis. Williams and colleagues 40 developed a gait classification system for people with TBI that includes 6 categories: spastic hemiparesis, non-spastic hemiparesis, ataxia dyspraxia unilateral, spastic bilateral paresis, non-spastic bilateral paresis, and ataxia dyspraxia bilateral. These descriptors provide a common, clinically useful method when describing gait limitations and communicating findings. Physical therapists use observational gait analysis, OGA, as a preferred method in the clinic to evaluate gait. 158. One instrument used clinically is the Rancho Los Amigos, RLA, OGA system. Refer to Chapter 7, Examination of Gait, for further discussion of this instrument. The RLA OGA instrument gathers data on the cyclical movements of walking that occur from one stride cycle to the next. The gait cycle is divided into stance and swing phases. The PT visually analyzes our patient's walking pattern, looking for asymmetries and deviations from normal. Based on these observations, the PT gains insight into which impairments may be causing the deviations. Specific interventions are then designed to address the possible causes of the gait deviations. However, caution should be used when interpreting OGA findings. Some gait abnormalities identified by quantitative gait analysis may not be detected by OGA. 69. Chapter 7 also reviews instrumented walkways and other methods of more precisely and accurately measuring specific kinematics and kinetics associated with gait. Gait speed is also an important measure of walking ability. The 10-meter walk test, 10 MWT, is a reliable measure of both fast-paced and self-paced gait speed in patients with TBI. 159-161 caution to be used when interpreting gait speed measured with the 10 MWT, because there is evidence suggesting that the 10 MWT may not fully reflect the many different demands of walking in the community. For example, crossing a busy street, walking in a crowded mall, walking on uneven surfaces, etc. 0.161 Fatigue and deconditioning are common following TBI. 162,163 as such, measuring walking endurance is clinically useful. The 6-minute walk test, 6 MWT, is a common, reliable, and valid way to measure this aspect of walking ability. 164. 165 normative values in healthy adults are available for this test. 166 other methods of assessing cardiorespiratory fitness have also been validated for patients with TBI, including the graded exercise test 167 and a modified shuttle test 168. Several tests of dynamic balance, see above, and walking ability are appropriate for this population. However, they do not offer insight into how walking and balance are affected by the addition of a cognitive load. Measures of dual task performance allow the therapist to examine the extent to which deficits in attention and memory affect gait speed and safety. These two cognitive abilities, attention and memory, are strongly associated with dual task performance and also commonly impaired in persons with TBI. 169,170. There are a variety of clinical tests of dual task performance that can be used for clients with acquired brain injury. A review of several dual task performance measures is available. 171. One such measure is the Modified Walking and Remembering Tests, WART, developed by McCulloch et al. 169. The WART involves a single task condition, simple walking task, and a dual task condition, walking task and cognitive task. Further information on these and other outcome measures specifically used in rehabilitation can be found at the Center for Outcome Measurement in Brain Injury website, www.tbims.org/combi/index.html. At the Shirley Ryan Ability Lab Rehabilitation Measures Database, www.sralab.org/rehabilitation-measures. And at the Academy of Neurologic Physical Therapy Outcome Measures Recommendations webpage, www.neuro.org Professional Resources Neurology Section. All trauma measures recommendations. Traumatic brain injury. Table 19.2 contains more detail on selected, highly recommended tests. Fan of Kegel's outcomes. People with moderate to severe TBI present with a wide variety of physical, cognitive, and behavioral impairments that may greatly impact the patient's ability to fully participate in his or her desired social roles. As the patient progresses, goals and outcomes will move from basic mobility and self-care towards skills that facilitate community inclusion and social participation. Examples include the following. Common impact of impairment is reduced. Risk of secondary impairments is reduced. Joint integrity and mobility are improved. Motor function is improved. Muscle performance is improved. Cognition is improved. Posture and control is improved. Ability to improve physical actions, tasks, or activities is improved. Walking ability is improved. Independence in ADLs is increased. Tolerance of upright postures and activities is increased. Safety of patient, family, and caregivers is improved. Ability to participate in social roles is enhanced. Ability to resume home management is improved. Ability to resume work, community, and leisure roles is improved. Awareness and use of community resources are improved. These can be used to guide the development of specific anticipated goals and expected outcomes tailored to each individual patient. Interventions, motor, learning strategies. Treatment sessions should be thoughtfully planned to maximize the patient's motor learning capabilities. Practice should be distributed with frequent rest periods. Owing to cognitive impairments, patients may experience mental as well as physical fatigue during treatment sessions. Signs of mental fatigue may include increased irritability, decreased attention and concentration, deterioration in performance of physical skills, and delayed initiation. Treatment sessions should include sufficient rest periods to minimize both physical and mental fatigue and maximize motor relearning. The impact of manipulating motor learning variables on motor skill acquisition and generalizability has not been thoroughly studied in patients with TBI. Refer to Chapter 10, Strategies to Improve Motor Function, for an in-depth discussion of motor learning principles. There are a few studies with a limited number of subjects, however, that suggest the use of video self-modeling 172 and the concept of self-generation 173 may be beneficial to the relearning of functional tasks. With video self-modeling, the patient watches himself or herself engaging in skillful behavior on edited videotapes. The self-generation concept is a phenomenon whereby items that are self-generated are better learned and remembered compared to information that is provided. As the cognitive and behavioral barriers to treatment become less intrusive, sessions can be progressively more challenging both mentally and physically. A random practice schedule may be more beneficial to learning. 174. Although this schedule can be employed only after the patient has demonstrated some initial learning of the task's dynamics, 175. Feedback is also very important. Metacognitive, sensory, and perceptual impairments, explicit or augmented. Feedback may be more beneficial in the early stages of motor learning as opposed to intrinsic feedback. However, care should be taken not to overwhelm the patient with feedback. Restorative versus compensatory-based interventions, as discussed earlier, an early, interdisciplinary approach to rehabilitation after TBI has been shown to be beneficial. There are many intervention approaches available to the PT that can promote functional recovery following brain injury. Two basic treatment strategies are a compensatory and a restorative recovery approach. The compensatory approach seeks to improve functional skills by compensating for the lost ability. A simple example of this would be teaching one-handed dressing techniques to a patient with UE hemiparesis resulting from TBI. A restorative approach seeks to restore the normal use of the affected UE. Both approaches seek to reinstitute functional independence. Compensation is commonly defined as the resumption of the ability to complete a task using alternative motor patterns and strategies. The definition of recovery varies. Some feel that it refers to the resumption of the ability to complete a task using the same motor patterns and strategies as before. Another, more liberal, definition is completing a task using similar strategies despite inferior efficiency, speed, and/or accuracy. Levin et al. 176 addressed this topic and proposed explicit definitions for recovery and compensation. The authors argue that the definitions of recovery and compensation will change based on whether performance or function is measured. To make this point clearer, the authors use the framework of the World Health Organization's ICF model. Refer to Table 19.3 for more details. In most cases involving moderate to severe TBI, clinical management will likely require a balance between both restorative and compensatory approaches. As an example, a therapist may determine that a restorative approach to gait training is indicated but may also choose to ensure that the client and caregiver have adequate training in the use of an assisted device for safety during the earlier stages of recovery should it be needed. Current literature offers little guidance for the practitioner attempting to choose between approaches. Table 19.4 offers questions that can guide this aspect of clinical decision-making. After a thorough examination and consideration of the patient's unique personal and environment barriers and facilitators, these questions can help lead the clinician and patient to a shared agreement about which approach will be used. The last decade of translational and applied research in the areas of neuroplasticity, motor learning, And neurological rehabilitation has heightened awareness that relearning is directly related to the rehabilitative experiences patients are exposed to. Using the example above, interventions that seek compensation will result in learning how to use the less effective UE as well as learning not to use the more effective UE. Alternatively, a restorative rehabilitative experience that allows the patient to practice using the affected arm for everyday tasks will result in greater functional independence and effective UE use. This knowledge is useful in clinical decision-making when developing the POC. Restorative interventions and neuroplasticity. No studies to date have identified what types of restorative interventions are the most beneficial for persons with TBI. Current research has demonstrated that task-specific interventions with large amounts of practice can induce beneficial neuroplastic changes in the CNS and restore function. 179 studies involving monkey and rat models of brain injury have demonstrated the importance of intensive task-oriented training on neuroplastic changes in the motor cortex and functional recovery. 181. This line of research was extended to include human models with neurological deficits, and later the sum of these findings was translated into tangible principles of experience-dependent neuroplasticity. 182. Table 19.5 provides examples of several of these principles. Current evidence suggests that treatment interventions that are most beneficial will be specific to the function task being retrained, meaningful to the client, and challenging to the cortical systems involved in the activity.
Okay, so I added a little bit of reading um, than what was given in the PDF. That can't hurt, right? So all these pages were read. And then I'm going to do a two-part video, a part one and part two. In part two, we will go over the boxes and the tables from the O'Sullivan book. This table, this box, a little bit more in detail, as well as this table in conjunction with the therapy ed slides here. And so that will make two, part one and part two. So part one will just be mostly the reading from the book. Okay? It's almost 45 minutes. So be looking for part two.